The next topic is by Dr. Anilkumar on sensitized recipients on wait list. 10 minutes followed by 5 minutes of discussion. That's all. Can't exceed that. Next.
I can do it here also.
नहीं होगा पीपी वर्मा का ड्रिंक भी है ना.
Good evening. At the outset, I would like to thank the Mumbai Kidney Foundation for giving me this opportunity.
Louder.
So, I'll start with the journey of this patient, Mrs. PB, who's a 54-year-old lady who was hypertensive since 24 years. Diagnosed CKD in 2009 when the creatine was 1.9. In 2015, her creatine was 6. She met a nephrologist and a biopsy was done, which showed chronic glomerulosclerosis. 2016, dialysis initiated. 17, she registered for deceased donor transplant in Karnataka. Her sensitization history included blood transfusion of 1 pint and 2 pregnancies. There was one abortion. There were no complications, major complications during dialysis. Pre-transplant evaluation, there was subcritical coronary artery disease. We didn't do a PRA because at the start when she was registered. From 2020, she used to get calls from the allocation team. That time in Karnataka, DSA lysate cross-match was used as a basis for allocation. Initial 3 times she was DSA cross-match positive. That's the reason we did a Luminex single antigen bead assay. So we can see here on the left-hand side, right-hand side, a lot of antibodies. A, B were all less than 5,000. In class 2, DRB was more than 5,000. C, though they are more than 10,000, they are not of much significance. 3 more Luminex DSA cross-match reports were positive. From September 2021, in Karnataka, we changed the policy of allocation. We thought that DSA lysate there were more DSA lysate cross-match being false positives. So it was decided we go back to CDC cross-match and also HLA typing for all disease donors. On 6th April, we got another call from the JSK. CDC cross-match was negative. Organ was allotted to us. But because of our previous sensitization history, we had a single antigen bead and we had a donor HLA typing. We refused the donor that time because she had DSA against B40, which was 3,000, and against DR7, which was 7,000. So anything with more than 5,000, we thought will not take a risk. On 28th of June, we got another call. This time also CDC was negative. We did a virtual cross-match and there was only antibody to one antigen, B40, which was 3,000 odd. But unfortunately, this patient was not first on the list, so she was not allocated the organ. So on 16th of July, that is after a month later, she again got a call. CDC was negative. We did a virtual cross-match. This time she had 3 DSAs against 3 antigens, but the MFI values were less than 5,000. We thought we'll go ahead because there was almost a patient was getting restless. It was almost 6 times, no, 6 times, 6 plus 2, 8 times she had gone for a cross match. So we accepted the donor. So we did one session of plasmapheresis pre-transplant. We gave ATG induction. So after 4 days, we sent again a single antigen bead. During this time, her urine output improved, her renal functions were improving. The SAB, the current SERA, what we did was B35, there was which was 4,000 earlier, it had increased to 6,400, but there were no other DSAs. So before we thought we'll do plasmapheresis, our next day her creatinine increased from 1.8 to 2.43. We did a biopsy. Unfortunately, it was C4D positive ABMR with thrombotic microangiopathy. So we thought that time we had to use eculizumab, but we did just a plasmapheresis alternate days with low dose IVIG followed by rituximab. Fortunately for us, her renal functions improved to 1.06 on POD 21. We did monitor CMV and BK virus. CMV on the first month itself, while on prophylaxis, her titers were around 13,300. So we escalated her Valga enciclovir. Fortunately, it improved by the end of the third month. It got undetected. BK virus was negative. Post-transplant immune monitoring on the first week, first month, third month, and ninth month we did. The B35, which was 6,400, it reduced. By the end of third month, we had no antibodies. So we didn't do class 2 that time because only class 1 was present. Probably by 1 year, we have to do both class 1 and class 2 antibodies. The current status is 10 months post-transplant, creatinine is 0.8, and there is no albuminuria. So what is sensitization? Sensitization refers to a recipient state before transplantation in which HLA antibodies are circulating in the blood, or to the potential for rapid production of HLA antibodies immediately after transplantation through an immune memory response. The risk factors we all know, out of this, previous transplants carries the highest risk. Next comes pregnancy. All over the world, there are around 30% of the patients waitlisted who are sensitized. 15% of them are highly sensitized, that meaning CPRA of more than 98%. 14% of them who are non-sensitized may become sensitized because of de novo donor-specific antibodies. And 47% of pre-sensitized renal patients may become seronegative because of tolerance or because of the TREGs cells. So the HLA antibodies may be either donor-specific or non-donor specific. They may be complement fixing, or they may have the different IgG subclass. IG1 and IG3 subclass are more complement fixing, and they are more risk to cause acute rejection, whereas IG2 and IG4, they are not complement fixing and they may cause chronic rejections. So if you see on the left-hand side, with the complement fixing antibodies are more dangerous, the graft survival is significantly lower if we have HLA antibodies which are complement fixing. So we have different methods to detect HLA antibodies. The left-hand side, we have the cross-match, the old cell-based assays, and the right-hand side, we have the solid phase assays. The solid phase assays are more sensitive as well as specific. And what happens is when at times when you don't have any antibodies, when we test the sera, but we still encounter rejection. This is because of the cellular memory. The cellular memory is because of the previous sensitization, especially previous transplantation. Yeah. And when they are exposed to the same antigens post-transplant, there is a accelerated response, and these antibodies are normally not detected in the serology. There are a couple of tests like ELISpot test, we can detect the cellular memory. So if a patient is on a waiting list, what all we have to do? We have to do a HLA typing, we have to do a PRA, we have to do a single antigen bead. So in India, it is not possible because of the cost constraints. Probably we have to do a PRA, and if it is positive, we can do a SAB. CPRA, in the West, we do CPRA, virtual cross-match, and a final cross-match. So panel reactive antibodies can be assessed either by cell-based methods or solid phase assays. So solid, in the last 15 years across the world, Luminex-based solid phase assays where we do a PRA skin can be done to detect PRAs, or more specific could be a single antigen bead HLA antigen specific method. We get more quantitative assessment here, but again, this is expensive. It will cost around 34,000. So ideally, we have to do monthly or quarterly, or at least once in 6 months. And every time when there is a sensitizing event, we need to do a PRA test at least after 15 to 30 days. So both are important, the peak, the historical PRAs and the current PRA. So what is peak PRA? It is the maximum historical panel reactive antibody percent. Because why this is important is you may have at the time of transplant no antibodies, but there may be something called a cellular memory. These are very important. So they may cause acute antibody rejection immediately after transplant. This I'll not go into detail. This is what the UNOS uses for allocation of the organs. So based on the previous donors of last 5 years, around 12,000 kidney donors. So we see whether this particular recipient has got any antibodies against some particular antigens. They are called as unacceptable antigens. And the allocation is based on the presence of these unacceptable antigens. Actually, based on the percentage of PRA, we can actually predict what is the possibility that this person may chance of getting a compatible donor. So if you have a 76% PRA, it means that there is only 25% probability to get a donor. Actually. So by knowing the SAB, single antigen bead assay, and the donor HLA typing, we can calculate predict the cross match. It is called as virtual cross match. So here I have given actually on the left hand side, you have a single antigen bead assay where you have the what all anti-HLA antibodies this particular recipient has. So whenever you get a donor, there are the 3 set of donors here. On the top and yellow mark donor there, he's got A2, which is more than 20,000, B8 also 18 also more than 20,000. So we can predict this patient will definitely get a positive cross match. So there is no need to do a physical cross match. Before doing a physical cross match itself, we can tell he's going to have a positive cross match. So in the second, in the donor, there is A3 and B13, but the MFI titers are all less than 2000. So here the DSA is positive, but we may predict a negative CDC cross match and a flow cross match. Sometimes we can go ahead with the transplant as well. And the last donor, there are no DSAs, so we can predict a negative CDC and a flow cross match. So here, this is a risk stratification. So if the DSA is negative and a positive CDC, we should not go ahead with the transplant. If DSA is positive, flow is positive, but CDC is negative, we can go ahead, but there is a high risk of AMR. So if DSA is negative, but flow is also negative, okay. So if the DSA is negative and if there is previous sensitization, there is a possibility of a cellular memory. There is also a risk of rejection. So what are the deficits in India? So we don't have a common allocation policy, and still CDC crossmatch is done in most of the centers, and also Luminex, because there are a lot of false positive. We should not use this. Flow cytometry would be ideal, but there are some constraints for the HLA lab people. So the most effective way for Indian population is to do first do an initial PRA, probably with the pooled sample, which will cost around 6,000 rupees. Then if it is positive, we have to do a single antigen bead assay. Then subsequently a HLA typing of the donor at the time of transplantation. So we can do a virtual cross match and a final cross match. So what are the approach for a transplant recipient who is sensitized? So we can change the allocation policy. There are in the West, they are given points. So if you have a 80% PRA, they are given around 25 points. If it is 90, it is around 50 points. If it is 100, they are given 200 points. So so these are the two different changes was done in the UNOS in 2014. So they gave more points. In Europe, they did an acceptable mismatch where if you see a lot of donors, there may be antibodies to no antibodies to some particular antigens. So you can add into the phenotype. So paired exchange, yes, paired exchanges. So over the last couple of years, the last 10 years, earlier it was thought desensitized will change things, but the interest is becoming lesser and lesser because it is more expensive, more resource intensive, and carries a very high risk of morbidity. Probably a few patients may fall into the group. A lot of drugs are there for desensitization. Some promising drugs are IDIS, that is cysteine protease, and couple of these drugs actually. So Jordan has done a lot of desensitization on this thing. So this is his protocol. I will not. Okay. So in India, the last slide, it is tough because our disease donor allocation policies has to change. We need prioritization for the sensitized patients. National paired exchange programs has to come so that a lot of our patients can be put into the program. Desensitization, if there are no living donors and DSAs are low, could be possible, though it is an expensive and carries a very high risk of infection. So this is my conclusion. Thank you.
Thank you, Dr. Anilkumar. 2-3 minutes for question answers. Mike, please.
Seems to be getting the insulate typing done in time, because once the organ allocation process starts, then it is all fight to finish, and there is no time for HLA typing results. And that, how do you do it in?
So in Bangalore, in Karnataka, we have 3 zones. Only in the Bangalore zone, there is the Mangalore zone and the Gulbarga zone, and now there is another zone, Hubli also. There are 4 zones. In Bangalore, what we do is there is only one center which does the immunology lab is in only one center. So the sample is gone, and with the SSOP method, they do within 4 to 5 hours, they do the HLA typing. So it is only 2-digit typing. So you don't get the high resolution typing, and most often it is enough actually.
Yeah.
Can I comment?
Yeah.
So it was excellent talk, and I think this is we are facing more such situations, particularly with in the areas where we have a good disease donor transplantation program. So I come from Telangana. I think we have a very good disease donor transplantation program, and we see patients who are sensitized, like high PRA, second transplant, third transplant, being they wait in the waiting list with who are sensitized and they require desensitization protocols. And as you said, we have a the scores for, particularly in the West, we have a scores for such patients. But as of now, though ours is one of the best model, I think it's very difficult, as sir has said, it's very difficult to get the HLA done. And what I believe is even in Karnataka, it's not being used for the organ allocation.
No, it is not used for
for their benefit only
Yes,
to assess the
yes.
the subsequent.
So when we
outcomes.
change back to the CDC typing, there is now a lot of debate why we are going back to CDC typing, because it is a very least sensitive. But we thought that if at all some of the highly sensitive, if they have already done a single antigen, if the CD is positive, you can still have a chance to refuse that donor.
Yes, true. And I think in India only it is the Gujarat who's following this HLA typing being done and the HLA match, and then giving prior to patients who are highly sensitized. So, and that is also a problem with that system, because always it's so. And I was discussing with Vivek Kote, he said it's very difficult to find a match. And there's always, a problem in allocating the organ, particularly in the odd hours when we have, time is a more important factor. And the top in the list are occupied by the highly sensitized. And we are always giving organ to our patients who are transplanted and then again waiting the list.
Yes.
And we are never given to patients who are naive and they're just waiting for the transplant for the first time. So it has its own, flaws for including the such patients. I think
Last
India,
comment from Amit. Yeah.
premature now to have that into as allocation system.
Dr. Pathak's next time.
Yeah, actually,
Amit,
as you
yeah.
said rightly, most of the desensitization protocols are not very effective.
Yes.
I mean, as that's shown in the literature. So at the end of it, would you suggest that we should attempt desensitization or go in for?
Probably in India, actually, if we have a this thing where we have a titers of a single titer against directed and single antigen, which are less than 5,000. Probably in those cases we can, because if you don't have a living donor option for a paired exchange, or your allocation policy, he has to wait for more than 5 to 8 years. So probably it's the only very few circumstances we can try.
New IL-6 which has now been in.
Tocilizumab, we have a lot experience with when we are treating COVID-19 patients. So in Jordan, what he did, their policy was to give IVIG 2 grams per kg, 0 month and 3rd month, first month, at the end of first month, and in 15 days they give rituximab. If this fails, then they use tocilizumab 800 milligrams per kg.
Another one which has now been there's a recent publication on a newer anti-IL-6.
Yes,
this is after tocilizumab.
Yes.
Yeah. So thanks very much. We have a lot of further topics to be discussed, and we are already running late. Thank you, Dr. Anilkumar.